Are you curious about how to ensure the best vision for yourself and your family at every stage of life? Today, I'm once again chatting with Paul Graham, a leading Gold Coast optometrist with over 30 years of experience, who's the owner of Harmony Vision Care. From understanding when to get your child's eyes checked to looking at why young adults might experience deteriorating vision to exploring how adults over 40 can ditch their glasses. Paul's about to share his expert insights regarding all these and more. But first, who am I? My name's Paul Salloway, owner of Optics Digital Marketing, an agency that helps independent optometrists to grow their practice. So, hello, Paul. Thank you for making time for this interview again.
Hey, Paul. Oh, thank you.
So in the last video we did, you gave us the background of Harmony Vision Care. So if anyone's interested, they can go back and watch that. So what's new on the Gold Coast there since we last talked? What have you been up to?
Probably the biggest thing is we just had the International Cornea and Contact Lens Congress. So that is hosted quite often on the Gold Coast in our own backyard, which is nice. But it brings in practitioners from all over the world to discuss all things cornea, contact lenses, dry eye.
And so I gather that there were some good discussions around keratoconus, which is a topic that we're going to touch on later as well. So it's good timing there.
Yeah, absolutely. So the sort of the top four things probably at these conferences are how we manage keratoconus and how we bring back good vision to people who suffer with that condition, what we're doing with regards to ortho-K, what we're doing with multifocal contact lenses, and dry eye is a really big developing field as well. Yeah.
All right, excellent. Well, last time we talked a little bit about sight screening in schools and
Yep.
early childhood eye examinations. So can you just sort of go over again, like what are the key differences between the sort of basic sight screening that kids might have in a school environment versus a full child examination that they might have in an eye care practice like yours? What are some differences there?
Yeah, look, and it's a really important discussion because, most families will, certainly in Queensland, they have a program where kids go through a sight screening in their prep year of school. It's nice to kind of talk about how the different terms like sight versus vision are used. And a lot of the time people might be using the word vision, but they really mean sight. So it leads us into a lot of vision screenings are really concentrate on the sight side of things. So sight is how clearly we can see, and that's typically measured by what you can see on a letter chart. And when you're dealing with kids, they tend to use pictures instead. And sight screenings have a really important role for picking up those types of eye and major eye and vision problems that develop before the age of 4. Things where, because the kids develop those things young, they may not necessarily outwardly show any kind of issues because they just kind of learn and develop with the vision problem in place, but it then can cause some issues later on. A lot of the testing centers around whether they've got a high prescription, so that's whether they've got astigmatism or long sight or short sight, how well they can see on a letter chart, and whether there's any difference between the two eyes. That's just, they're very important parts of vision, but they're only a small part of the whole visual process. And the nature of screenings is that they've got to get through a lot of kids in a fairly short space of time. So they're going to be picking on the more major eye and vision problems, things like eye turns, lazy eyes, and high prescriptions that you want to get onto early. And that's different from, one, if we're seeing a child of that age, there's so much more that we'll be testing because we're interested in how they process and perceive information, and in addition, doing more extensive tests of their eye health. I think the important thing to understand is that If we're talking about the kind of vision problems that are going to affect learning, then many of those kids will pass a sight screening. And so the vision problems that they get are a lot more subtle. And so that's where it needs more extensive comprehensive testing. And the other thing that can also happen is that the vision problems may start to develop once they're at school. So we need to be looking at things where they've genuinely passed a sight screening. They may even pass a full visual exam at 4 years old, but things can change and do change. So they can start to develop eye teaming problems. They can start to develop focusing problems, and they can start to develop myopia. And those are things that occur well after a sight screening's already been conducted. It might happen 2 or 3 years down the track. So it's easy to fall into the trap of, my child passed the screening and everything's okay. I think we need to recognize that, one, it is just a screening, and things change.
So those kinds of screenings, so they don't necessarily like check what's going on inside the eyeball or at the back of the eyeball. That those are the kind of like examinations that you'd really need proper diagnostic tools for, which they wouldn't have, I guess.
Absolutely. Yeah. So, the modern screening now with instrumentation, they're a little bit more sophisticated than they were, say, 20 years ago, where they can use instruments to pick up difference in the prescription between two eyes. So you might have a child who's very long-sighted in one eye, but you won't know about it because they see well with the other and they're not showing any outward signs. Well, they have instruments for picking up those differences. But again, we're talking about picking up the 5 to 10% of kids who have sort of more obvious developmentally based eye problems. But yeah, it doesn't look at eye health and doesn't look at those subtle things around, eye teaming and tracking and things like that.
And I guess often the children themselves don't know if they have vision problems, so they're not gonna stick their hand up and say, "Dad, Mum, take me to the optometrist," are they?
Yeah. And look, they don't always, and they don't know what blur is. And if they've been saying that way since they were younger, then that's their normal. I still remember having a young boy come in at 7, and this is back in the days where sometimes screening programs would come and go. They've been a lot more regular now. And he came in and he seriously couldn't see letters on the chart that were this big. And looking at him, he looked perfectly normal. He rode motorbikes.
Wow.
And he was not able to see things this big and had no issues riding motorbikes. And so he was obviously, I think we saw him at 7 or 8 years old because they were starting to notice that he wasn't seeing the other kids were seeing in the classroom. But there was nothing about his behavior away from school that would indicate anything, because he was so used to seeing like that. That was his normal.
Yeah. It's not even just kids, is it? I mean, I think I got my first set of glasses as an adult, and I think everyone who wears glasses probably has a story like this. When I put my glasses on for the first time, I remember I was at the optometrist office, and it was like 5:30 in the afternoon or something, and I walked outside and I could see like the sunset in like vivid colors, and I thought to myself, is this what a sunset looks like? I've been missing out on it all these years, So sometimes you just don't know you've got a problem until it's properly tested.
That's right. It's obviously if something suddenly shifts, you've got a reason to, your brain picks up on it. But if you get these slow changes over time, then you kind of just adapt, and it's not until you're confronted with something that you're performing differently to somebody else. And I've got a similar story with, seeing the leaves on trees that I didn't realize you were meant to until I got my glasses as a teenager and went, okay, I am meant to see that from this far away.
Yeah. Well, that maybe leads us to the next topic, which is children's eyesight. So, like when children are born, they're not blind. I have to assume, at least in most cases, but they're not. Their eyes aren't fully developed either. So there are like some developmental milestones that they go through, and so in those early years when our eyes are developing, and even perhaps later into teenage years, how often do you recommend that kids get their eyes checked, and like what are some of the key milestones there?
Yeah. And so it's really about, and again, if we move away from eyes and talk about vision, I mean, you basically, our eyes are tools that our brain uses to understand the world. And so it's really the brain learning how to move the eyes and how to interpret the information. And one of the first common critical points that we look at is by 6 months old, an infant has started to really organize how the two eyes work together. So you're wanting to check that they've hit that first developmental milestone, that there's no sign of what they call an infantile strabismus. And again, we're talking about a few percent of do that, but you still want to check. You may want to get a sense, particularly if there's a family history of eye turns or high prescriptions. That's a good time to start getting a sense of are these kids in where do they sit on the normal range? And at that age, there is a very, very broad range. So you're looking for sort of overall global signs that they're using the two eyes together, and that they're able to shift their focus, and everything's kind of looking healthy at that stage. So it's kind of a first marker. And certainly if there's a family history of high prescriptions from an early age, or a family history of eye turns or lazy eyes or eye surgery, someone's grandparent had an eye surgery when they were little, then I would be saying, look, you probably, that marks you as someone where having a general checkups are probably a good idea at 6 months old to get that first kind of bar set. Then the next phase is around the 2 to 4 year old age group, where they're starting to be more mobile. They're getting more control over being able to separate their eyes from their head and body movements, starting to pay attention to sort of finer detail. And you're able to get sometimes in that age, almost an adult test done that, if you're using the appropriate kids symbol chart rather than letters, you can quite often get a fairly good complete visual exam done. But you're starting to look at that more finesse in how they're using the two eyes together. You may even start, when they're getting at that 4-year-old end, start looking at visual processing. Are they starting to interpret things at an age expected level? Because you're starting to get into that pre-literacy kind of skills that you're looking for. And again, looking for any sort of deviations from normal visual development that the kid might not outwardly show. And then you move on to your real getting into your pre your school readiness kind of testing, and that's where we more heavily look at focusing, eye teaming, visual processing. And so we really want that happening around that sort of prep grade 1 kind of marker. And then it depends on the child's progress through school. If there's any concerns about how they're progressing, you may want to get them checked sort of annually, particularly if there's a family history of some issues. But after that point, then probably a couple of years later, you want to be looking into, we tend to loosely break them up into what are the learning how to read skills. And then there's using reading for learning skills. So when the kids are entering late grade 2, grade 3, there's a change in what's expected of them reading. Okay, so they're transitioning from learning how to decode words to then starting to actually extract a lot more meaning from what they've read. So the print size gets smaller, the amount of work that they have to read gets bigger, and they're having to comprehend a lot more. And so that places a lot more demand on finer eye teaming and focusing skills. And so we're starting to look out for those common binocular visual dysfunctions and accommodation dysfunctions, which is the sort of technical words for eye teaming and focusing issues. I was going to say, and then after that, it's, you want to patch in every couple of years because things change. And then you're also starting to look for signs of myopia development. And again, that's when you start to lose your distance vision. And that's particularly important. It used to be that if you had a family history, obviously that predisposes you even more, but it tends to be a modern life problem. And I think we discussed last time that the prevalence is really increasing in that one as well. So, it loosely comes around every 2 to 3 years is what you want to be looking at.
Right. So just to clarify, like what age is a good age to be thinking about myopia control? Is it like 5, 6 around there, or a little even earlier?
Yeah, look, it's a changing feast, and it depends on your demographics sometime, but certainly as old is where you get your first marker of being able to understand the likely risk of a particular individual maybe progressing towards some myopia. So we look at their family history, we look at what sort of activities they're into, how much time they're spending outdoors, and we're able to get also an idea from what their current level of prescription is. So even if they're not short-sighted yet, there can be sometimes some signs that they might be moving in that direction, and be able to counsel the family on how often we need to check them. It might become more regularly, and what sort of activities they and changes to their lifestyle that they should be looking at doing as a safety valve.
Okay. Well, one of the common treatments that I know that you recommend for myopia control is contact lenses, like ortho-K contact lenses, and even some of the other soft contacts like the MiSight lenses, because they have certain special technology built into them that reduces that stimulus for eyeball elongation, which causes myopia.
Yes.
Now, I guess, for a lot of people, contact lenses sound good in theory, until it comes time for them to actually insert them. And that's where we run into some challenges. So can you give us some tips, like what are some of the things to think about when we're learning how to use contact lenses, or when our kids are learning how to use contact lenses, if, for example, they have myopia?
Yeah, look, the kids can be it's a very much an individual kind of, you take each case as they come. I don't have any sort of strict cutoffs when it comes to the kids, but generally moving into contact lens wear, regardless of whether you're a child or an adult, the number one thing is it is a process. Okay, it does require some learning. It is actually quite a fine motor skill. It requires some patience. You have to get used to the idea of putting something on your eye. Sometimes, particularly for adults, sometimes it might be a bit challenging to actually see the contact lens. So we've got to work on techniques at learning how do I get this thing lined up on my eye if I have trouble seeing it. So the number one thing is just understand that it is a process and takes time. And I don't like any of my patients feeling like they've failed if they don't get it the first time. And I always say to them, the last thing I want to see is that you've given up way too early, or you felt like you were not good enough. And so I say, I'll keep going while you're motivated to get you there. And my own, I wear contact lenses regularly, and my own sort of journey was a little bit up and down. So I understand that, I'm one of those people that took more time. We can't get it first go. And so probably the number one thing is just being patient with the process. And I don't measure chair time in my practice from a success rate. If you're motivated, I don't see any difference between getting the lenses in and off the first time versus taking 10 goes to get it done. It's all part of the differences in everyone's journey. And that brings us to the other speed thing. A lot of people, they get nervous and they start to rush. And so one of the number one rules when we're learning how to take lenses on and off is just take your time, go slow. People are fearful of hurting themselves, and the eyeballs yes, look, they're our precious scents, and we treat them as they're delicate, as we should do, but they are actually reasonably robust. But we do need to take time, and if you're obviously concerned about hurting yourself, then going fast is not the answer. Doing everything slowly is the key one. I find that once people are able to calm themselves and just take time in the insertion removal process, that's when they start to become a lot more successful. Probably the final part of that is, if you're taking time, you become a lot more aware of where your eyelids are and how to manage those. I mean, that's probably one of the biggest factors of trying to get a lens on, is just managing how wide your eyes are, managing the control of your eyelids. And so, once you get your eyelids in control, once you're going slow, then the whole process becomes a lot easier.
Okay. I got to admit, I'm one of the biggest chickens in the world when it comes to like anything, like putting anything near my eye, like if you know whether it's knives, scissors, or knitting needles. If anyone in the room
Yeah,
has like
yeah,
got those, I'm giving them lots of space.
yep.
But still, you know, I got used to putting contact lenses in my eye. So if I can do it, anyone can do it. And I think that a lot of people have that initial, you know,
Yeah.
recoil about touching their eyes, don't they?
Yeah, look, and it's there for a reason. You know,
Yeah.
we have these protective reflexes, and you've got the logical part of your brain has to kind of override the reactionary part of your brain to sort of get there. And that's again, that's where that it's a time and it requires patience to kind of chip away at that.
And I guess hygiene's important as well, like making sure you know your hands are properly washed and that sort of thing. That's
Yep,
important as
clean
well.
hands, clean lenses, clean cases, absolutely.
Yeah.
You know, and we talk a lot about water being a risk factor for contact lenses, and you know, being very careful around water activities and getting water on the lens when you're inserting it. And, but the second biggest source of infections is actually dirty cases. So it's really important to keep your cases clean, replace them as you've been advised to do. And I think this is where kids often do really well, is that the parents being sort of in charge and supervising, they're typically the infection risks are very well managed by the parents compared to maybe some young adults out there looking after themselves.
So my experience with contact lenses was only the soft variety. I never actually even tried the RGP, the so-called hard contact lenses.
Yeah.
Do you get many patients who wear hard contact lenses? And if so, is it more of a challenge, or do you find that it's just much of a muchness between using RGP lenses versus soft contact lenses?
Yeah, look, when I first started my training, soft lenses were not new, but certainly newer. And back then, hard lenses were still the healthiest lens for your eye. And one of my mentors, and we talked about his son off camera, Damon Ezekiel. You know, his father was one of the pioneers internationally, and you know, Australians have got a very long history of being pioneers in various forms of the contact lens and ortho case space, which is something we can be quite proud of. And a lot of the instruments that we use that are some of the top in the world are actually created right here. I'm looking at purchasing another one after being at the conference, and there's some great technology coming out of this country. But what Don used to say was that hard contact lenses are hard on you mentally initially to get used to wearing them, but they're very soft on your eyes. That they still do have one of the lowest complication rates, but they are a challenging lens to get used to in the Australian environment, and what I find in Queensland, because of the heat, and our outdoor lifestyle means we're out in the dust and the sand and things like that. The old soft lenses used to be, Don used to say, soft on you mentally, easier to get used to, but harder on your eyes. But with the advent of, you know, newer materials, single-use wearing modalities, then, you know, a single-use lens is getting pretty close to the sort of low complication rates of a hard lens, but they still have a place. Hard lenses have their place for certain things. Without hard lenses, we wouldn't do ortho-K. Without hard lenses, we wouldn't be able to restore good vision back to people with keratoconus. I have to say that if I have someone sitting in my chair who's worn contact lenses for 40 or 50 years of their life, they're usually a hard lens wearer.
Really?
So they're still out there, absolutely. And so, you know, there's still a place for practices like mine where you still want to have a skill set and being able to fit them, because those people are still out there wearing them. And there's no good reason to necessarily move them into anything else while they're still doing well in them.
Well, to keep it personal for me, so I told you I started wearing contact lenses years ago, but then I stopped and I went to glasses, and I'm actually now thinking about going back to contact lenses for various reasons, and I know this will come as a shock to you, Paul, but I am over 40 years old. I guess that fitting someone with contact lenses who is sort of middle-aged or older is somewhat different to fitting a young adult or a teenager. So are there like differences in that whole process? And how would ortho K or other types of contact lenses suit somebody like me, for example.
Yeah, and look, the probably the two things that we deal with once we have anniversaries of our 39th birthday is probably the prevalence of dry eye is a bit higher.
Mm,
So we have to
mm,
be looking at managing that as part of our entry into contact lens wear, because contact lenses do demand more of your tear film.
mm,
So
mm,
we want to make sure that you're able to be comfortable. Maybe even just choosing the right, the right kind of lens material can help with that. Probably the second biggest factor is that if you were someone who wore a distance correction for, say, astigmatism or for
mm,
myopia when you were younger, when you were short-sighted, you would find that you had a single vision lens, corrected your distance, and it didn't matter what you picked up. You could look at something close, you look at something further away,
mm,
and you could see clearly at all distances because and I'll use the model from last time. Okay, the
mhm,
crystalline lens inside our eye changes shape, okay,
mhm,
when we're younger, and that's what defines what happens when you are in your 40s and 50s, that this lens starts to become less flexible. So the prescription you have to maintain good distance vision is different to the prescription you need to read. And that's when people start talking about wearing multifocals or bifocals or having to take reading glasses on and off and all of that sort of frustration. And so that's something that we're sort of dealing with when we look at what are the alternatives to wearing glasses. And we have to do effectively what we call a provide a depth of focus or simultaneous vision. So
mm,
rather than it being a multifocal kind of situation, which is different to the whole finding the spot in the glasses to wear, is that we set you up where you've got focusing available at all distances, and your brain has to use how to learn them. So there's a little bit of
mm,
getting the brain to learn how to do it, and that is entirely possible. It's we're not too old to learn, and again, it goes back to the patient's discussion. We need to be patient to understand that if we're really motivated to get some freedom away from glasses, then the brain needs to learn how to use these depth of focus lenses. And so there's a couple of ways we can do that. And one of the old methods was called monovision.
right.
So we had one eye corrected for distance, one eye corrected for near. The brain was able to use the peripheral vision from both eyes together, but then it would selectively choose which eye it was using for, say, the detail at near versus the detail at far. And if we're going to do that kind of correction, we can do that in a contact lens or ortho-K. So the overnight lenses that you sleep in, we can set up someone with a monovision kind of situation. It's a little trickier in ortho-K than fitting just distance only, and we need to sort of carefully choose who's going to be a good candidate or not. If someone's a good candidate for that, the advantage is that you're not wearing any lenses during the day, so it somehow negates those mild dry eye kind of situations.
Mm,
And we obviously check that as a case by case sort of basis.
right.
Yeah, probably the thing that we're doing more of is the multifocals and multifocal. And again, we prefer to use the word depth of focus, where you're wearing a contact lens on each eye that has both distance and near vision available, and your brain, over time learns to use which part of that focal length for various distances.
So the magic of ortho K is that it reshapes, at least temporarily, it reshapes the cornea, the front surface of your eye, doesn't it?
Correct.
Yeah.
I was going to say, and that's something where with short-sightedness, it's been very commonly used, and there's a few of us who are using it for that more long-sightedness kind of treatment. We have to be a bit more selective about who it works for, but if you've got someone who's motivated and getting a little bit of dry eye with contact lenses, that's certainly an option we might look at.
Well, so I was just going to say that, like, that whole front of your eye, the cornea. So there's a lot of, like, feel free to use your model there if you like, but there's a whole complex physiology in how our eyes work, and the cornea is an important part of that. And so before we started this interview, we were talking about keratoconus, and how you talked about that with your colleagues at the recent conference on the Gold Coast. So maybe this is something that a lot of people don't know about. So I wonder if you can just sort of like give us give us an introduction to what is keratoconus, what does it mean, and and yeah, like what are some of the things that we're learning about it now?
Yeah, yeah. And look, so the keratoconus is quite common on the Gold Coast. And so, we've got a fair bit of experience dealing with how we restore sight to someone who's got keratoconus. So we have the cornea, which is the clear window on the front of the eye. It's the first really part of the lens system that the eye is. And so we generally talk about it being a fairly spherical, regular kind of shape. Technically not true, but for our intents and purposes, it is. With keratoconus, what ends up happening is that you end up getting irregularities in the shape of that cornea because it starts to bulge. Back when I was first learning about keratoconus, we would have said, it's probably 1 in 2,000 people had it. There's probably more like 1 in 100. It's not because there's more people with keratoconus, is that our equipment that we can use now, and that's some of the Australian-made equipment that I was talking to, where we can get very good electronic shape maps of the front of the eye. They're very, very sophisticated. So even mild cases we're able to identify. Now, they may not be people who progress to needing specialty contact lenses. They may get away with regular glasses or regular soft lenses. But we do think the prevalence is a lot higher. And they talk about it being a combination of nature versus nurture, like a lot of things. So the nature being that, yes, it is inherited, but it's not like, your dad had it, so therefore you'll have it, and therefore your kids will have it. I think the sort of hereditary is like, 1 in 10, and not necessarily directly in that generation. Atopy or allergy seems to be a big component, and one of the number one bits of advice out there is that if you have itchy eyes, do not rub them. If you're the 1 in 100 who has the predisposition to having keratoconus, the last thing you want to be doing is rubbing the eye, because what happens is the cornea is made up of collagen fibers that are lined up over each other. And in keratoconus, they're not well stuck together. So you have the natural pressure from inside the eye pushing against the back of the cornea. Well, if you then go and rub the front, okay, you've got pressure in both directions, and those fibers start to slide. And if they start to slide, then the cornea becomes thinner and it starts to bulge out. Now, if it bulges, it's not a spherical shape anymore, and we can't use a regular lens to correct your vision. Okay, so the number one thing is, like anything, prevention is better than cure. Avoid the eye rubbing at all costs, and if you have itchy eyes, go and see an optometrist to get some assistance in treating that allergy. Is probably the number one first step. And keratoconus can be, it's not super common in 9-year-olds, but that's certainly the youngest I've seen. And so we need to be mindful of it even in our kids and teenagers. And it's typically most progressive between teenage years and 30 years old. And that's the key time where you really see the progression. Yeah, so eye rubbing is the number one thing to avoid. If you are unfortunate enough to then develop keratoconus, then you might find that it starts out that you have a little bit of blurred vision, you get some glasses that makes it a bit better, but down the track, either your eyes are changing very rapidly, and it may get to a point where you'll find that even with glasses on, you're just not getting satisfactory vision. It's always blurred. You might get starriness and flare at night around lights. You might have tried some contact lenses, but you're just not getting satisfactory vision with it because, like I said, that shape is no longer what we consider regular. Okay, it's out of shape now.
I've heard some optometrists described as like being the pointy end of a football, whereas like instead of being more like a soccer ball and regular, it's more elongated, isn't it?
Yeah, probably the one example is that they talk about where they give different names to different types of keratoconus. And the two common ones are what we call a nipple cone, and one's called an oval cone. And it's called a nipple cone because it's like a little bump popping out of a round surface. So and so it's almost like a peak rather than the key part is that the center is a completely different shape to the tissue just beside it. It's very, very steep in the center, and then it becomes, yeah.
And there are some like surgical remedies and also non-surgical remedies for keratoconus, aren't there? So can you tell us a little about those?
Yeah, and so a particular treatment that's become a very important part of progression control is a thing called cross-linking. So this is where if we pick up keratoconus in someone, then we're going to work with eye specialists, refer them to eye specialists who have the skills to provide corneal cross-linking, where what they're trying to do is get those collagen fibers to stop slipping, okay, and freeze them together. Now, unfortunately, that if you've had some reasonable change in your corneal shape, it doesn't necessarily put it back to normal anymore. The whole idea is to stop it from progressing. So we still may need to use sort of special types of contact lenses to get you clear vision again. But the key part is we want to be able to try and stop that eye from changing as well. There are other forms of surgery that once you've had cross-linking, they might look at certain types of corneal implants. I've seen those sort of come and go. Some surgeons use them, some surgeons don't. Probably the critical part is getting an opinion for cross-linking, though, in the early phases of finding out that you've got keratoconus.
And I guess the non-surgical solutions would be like specialized contact lenses, for example, scleral lenses. Can you tell us what they are?
Yeah, so again, if we think back to this discussion around hard lenses, what is a hard lens? Well, it's a hard plastic, and the advantage of that is it provides a round surface again. And if we have a look at the way a hard lens bends light, so we look at the cornea bends light, water bends light, and the tear film is effectively water. And the hard contact bends light. So when you put them all together and the tear film fills up the gap behind the cornea and the lens, it all becomes a brand new lens. And now the contact lens provides that smooth round surface to look through again. Whereas a soft lens, if we've got a bumpy cornea, the soft lens goes on and then just wraps to it. So that's why they're not very successful at correcting it. We want something that's going to clear over that bumpy part and provide a nice round surface again. And that can vary anything from a special version of a traditional small hard lens, and it might go to something that's as big, if not a little bigger than a soft lens, depending on the needs of the particular patient. It does require some specialized equipment and trial sets to be able to do that. So, one of the things we invested in early in the practice was a topographer, and that's where we can get some very good sort of shape maps. But usually we're then using sort of a combination of software programs to design lenses and actual fitting sets to be able to find out an individualized lens for a patient.
All right, Paul. Well, I think there's been a lot of really good information coming out of this interview. Something in there about something of value for young kids, for teenagers, for young adults, and even us grey hairs. I think that we got some good tips from that. Just remind people how they can get in contact with you and your practice.
Okay, so we're it's harmonyvisioncare.com.au. Phone number is 0755205900. We're on the Gold Coast and Varsity Lakes, and you can find out more about our services on the website, and you can even book appointments through there, and like I said, the phone number's there if you feel like you wanted to discuss your situation a little further with us.
All right. Well, so if you are watching this and you found this content valuable, don't forget to hit the like button, because it really helps us out in the YouTube algorithm, and also hit the subscribe button if you'd like to be notified when Paul releases more highly valuable YouTube videos like this one. So, all right, Paul. Well, thanks a lot once again.
Appreciate the opportunity. Thanks, Paul.
Okay. Goodbye, everyone. Have a great day.